Good afternoon. Hello, I am Karadina Sea with the Community Technical Assistance Center at New York University's Silver School of Social Work's McSilver Institute, and I'd like to welcome you to today's web-based training called Youth Suicide, Risk Assessment, and Safety Planning with Dr. Nicholas Westers. During today's important training, we will learn about youth suicide statistics, screening tools, and safety planning for a young person who is at risk for suicide. Before we get started, I want to take a moment to orient everyone to our Zoom webinar system so you know how to participate in today's event. Please note that upon joining, you are placed on mute to avoid any background noises. If you come across any technical issues during today's event, please chat to our host who will be able to assist you. Her name is Kiara. Please submit any questions you have at any time for Dr. Westers in our chat. We will be collecting them throughout our time and share them during our Q&A. And lastly, for the best viewing experience, you can go to the top right corner and click view and click side-by-side :speaker. Many thanks to Dr. Nicholas Westers for presenting today. Dr. Westers is a clinical psychologist at Children's Health and an associate professor of psychiatry at UT Southwestern Medical Center. He is board certified in clinical child and adolescent psychology and serves as a current director of programs for the Society for Adolescent Health and Medicine annual meeting and is chair of the Media and Communications Committee of the International Society for the Study of Self-Injury. His clinical and research interest focuses on adolescent non-suicidal self-injury, depression, and high-risk behavior. And he is the host and producer of the Psychology of Self-Injury podcast, a resource for parents, professionals, and people with lived experience of self-injury. Without further ado, I will pass along to you, Dr. Westers, and thank you so much again for joining us.
Thank you, and thank you for having me. And for context, I work in a hospital outpatient clinic where I only see teenagers, and the majority, if not all, have experienced suicidal ideation, and most have attempted suicide. And so we do a lot of safety planning and a lot of risk assessment. And so that's kind of why I'm pretty passionate about talking about this as a topic. Kara had already mentioned that this is an overview of what we want to do today is talk about the latest suicide statistics, including suicide thoughts and attempts versus actual suicide deaths, and what we know on the most recent data, which obviously takes a while for us to process and actually analyze. And then talk a little bit about screening tools. I don't want to talk too much about those or the suicide statistics, but want to focus a lot on the safety planning and talking about counseling on access to lethal means. And at the end, we'll do time for questions, answers, discussion. But I'd like to get to know you as an audience first. I'm curious to know, because we have a variety of individuals here from different disciplines, different backgrounds, different trainings. When it comes to safety or completing youth suicide risk assessments and safety planning, how comfortable do you feel? And there's a little poll that popped up, and I'll give you guys, all of you, a moment to complete that to see where you are today. And I know people are still joining, so we'll see where we are with the poll in just a moment. All right, I think that's probably sufficient time. And the results. Okay, so a good portion, almost half, feel fairly comfortable. So a lot of this probably won't be super new to you. So those of you feel comfortable and confident in it, it's great to have you. And hopefully you can, this will be a good review and helpful for you in sharing with your colleagues. And for the other half, hopefully this is going to be helping you to feel more comfortable, more prepared in working and treating adolescents who may be considering suicide. All right. From 2007 to 2015, the total number of child and adolescent visits to U.S. emergency departments for suicidal thoughts and attempts actually doubled. So a lot of you already know these statistics, and presented here are data from the two most recent youth risk behavior surveys conducted by the CDC, which they do every 2 years, that show suicidal thoughts and behaviors among representative samples of 9th through 12th grade students in the US. And although suicidal thoughts and behaviors among youth decreased from 2015 to 2017. They actually increased significantly from 2017 to 2019. And then 18.8%, you can see here, of US high school students reported having seriously considered attempting suicide during the 12 months before the survey, and then 8.9% reported attempting. And I know most of you are in New York, so I added a column for you to compare kind of where youth in your state compare with the national statistics here. The YRBS data for 2021 has not yet come out this year, but should likely be released this summer. And when it does, I always nerd out on the data. I know some of you are probably similar to me in that. Fortunately, though, last month, the CDC published the Adolescent Behaviors and Experiences Survey, or ABES, as the first nationally representative look at the effects of the COVID-19 pandemic on the health of our nation's youth. And ABES it's a 110 question online survey completed by 7,705 US high school students across 128 different high schools in January to June of last year, so 2021. And they found that the COVID-19 pandemic affected youth in a number of areas. And as you can see that 19.9%, or really 1 in 5 high school students, reported having seriously considered attempting suicide during the pandemic, during that span of the pandemic, and 9% actually attempted. And then sadly, of course, our nation's lesbian, gay, and bisexual youth are at the greatest risk, with almost half seriously considering attempting suicide, and more than 1 in 4 reporting actually having attempted. And compared with those who did not feel close to persons at school, students who felt close to persons at school had a significantly lower prevalence of poor mental health during the pandemic and during the past 30 days, as well as of persistent feelings of sadness or hopelessness, and of having seriously considered attempting suicide and of having attempted suicide. So 14% versus 25.6% reported having seriously considered attempting suicide if they did not feel connected to someone close at school. And then similarly, students who were virtually connected to others during the pandemic, that is with family, friends, or other groups by using a computer, telephone, or other device, they had a lower prevalence of poor mental health during the pandemic and during the past 30 days, of persistent feelings of sadness or hopelessness, and of having seriously considered attempting suicide, 18.4% versus 24.9%, and of having attempted suicide, 8% versus 12.2%, compared with those who were not virtually connected to others during the pandemic. But what do we know about suicide deaths so far in the pandemic? So this is 2021 data. Of course, we don't have 2022 data yet, and it'll be probably at least another year or 2 before we have that data. But here's a breakdown of the top 10 leading causes of death among different age groups. And as you can see, suicide is the leading cause of death. The second leading cause of death among those ages 10 to 14 and 25 to 34. And when it was the second leading cause of death of 15 to 24-year-olds, but has since dropped to the third leading cause of death for that age group. And those are actually the raw numbers underneath there. And you can see 5 to 9-year-olds. This is the first time I've seen suicide pop up as one of the top 10 leading causes of death. And there's a raw number of 20 children who had died by suicide. And we know in younger children, typically it's related to significant abuse or significant bullying and as a trigger for suicide. And then pulling data from the National Vital Statistics System, we can see changes in rates of suicide for all age groups right here, which shows an increase in Q2 in 2020, so halfway through 2020, to Q2 of 2021 of last year. So halfway through last year, comparing those two numbers, there was an increase among 3 age groups, 5 to 14, 15 to 24, and 25 to 34. So basically all young people had an increase in suicide deaths during that period, but it actually decreased the year prior. So from 2019, looking at to 2020, there was into the pandemic, into the first 6 months of the pandemic, there was actually a decrease in suicide rates. And now we've seen kind of they're coming back up. And this is a closer look. Those are all the age groups, but if we look here at the ages 5 to 14 and 15 to 24, you can see that there was 13.8 per 100,000 deaths. There were 13.8 deaths per 100,000 among 5 to 14, among 15 to 24-year-olds, and then you can look at the 5 to 14-year-olds below that. It was 1.3 per 100,000 there, and that increased to 15.0. So that was a statistically significant increase in the suicide rates there, looking at the crude numbers. And I know I had mentioned the 19.9% and the 9% when it comes to the ABE study that looked at from January to June of 2021, in which 19.9% of high school students had seriously considered attempting suicide, and 9% actually reported having attempted suicide. I think these are numbers worth memorizing and committing to memory as mental health professionals to be able to speak on this issue of like what is going on in our nation and among our youth during this, what they would call it, this mental health crisis. And so being able to say, yes, 1 in 5 students, high school students throughout the US are reporting seriously considering suicide. We all know this is a problem, but to what degree? And so that's the highest number I think I've ever seen in the YRBS data. Maybe spanning back a couple of decades, it might have been that high, but I'm pretty sure it's been the highest. And then breaking it down by method, this is going to be an important part when we talk about safety planning and restricting access to lethal means, or at least counseling on access to lethal means. A lot of people don't realize that, a lot of people do realize that firearms account for more than half, about 53% of all suicides are by the use of firearms. And we can look at the data in 2020 that looks at from ages 10 to 14 and 15 to 19. If you look at 15 to 19, you can see 48.2% of deaths were by firearms. That actually jumps to 50% when you extend the age to 21. So 15 to 21, then it's actually at 50%. So firearms account for over half of all suicides in our country. We know that suicide attempts are high, yet about 97% of suicide attempts do not result in death. And if we look at the methods, I know one thing that we see often, and this gets tricky, by the way, like I should have given this preface, this is a hard talk. We're talking about suicide. I know some of you have lost family members, friends, colleagues, just people that you know that have died by suicide years ago, or even like during the pandemic. And so I hear you, and I want to be sensitive to that and not just say, hey, these are just numbers, but this is a concern, and it's real. These are real people that we're talking about, and these are real numbers, not just statistics. A lot of the kids that I see when we're talking about safety planning, we talk about locking away sharps and knives, and in reality, I'm more worried about firearms. In my intake, I always ask about firearms and how they're stored. I have like an intake paper that I'll ask families to complete in case the kid doesn't know there's a firearm in the home. I don't necessarily want to introduce that if they are struggling with suicidal thoughts, though I have the parents complete that on the paperwork, and so that I can see how the firearms are stored if they are in there. And in the event that the kid that I see that I treat becomes suicidal or has acute increase in suicidal thoughts. And then I'm also concerned about hanging, because it's really, suffocation is the second most common method of death suicide among 15 to 19-year-olds, but the greatest reason for death among suicides among the 10 to 14-year-olds. And it's really concerned. But a lot of people are talking about sharps in objects, and less than 1%, so actually 1/2 of all deaths by suicide are by cutting or piercing, whether stabbing oneself or cutting oneself. So a very, very small number of deaths occur through cutting. Now, thanks to 13 Reasons Why, that Netflix series, there's this whole, I think they may have removed that scene, but a little bit, too little, too late, but kind of demonstrated how to do so. And I don't know if we have the data during that span when it was released, if there was an actual increase in percentage of deaths by cutting and piercing among adolescents and young adults after that. So but you can see that, so it's methods matter. And we know that if we can decrease access to one method, an individual is unlikely to, they may, but they're less likely to consider another method. But as we go into safety planning and screening tools, I want to do another poll here. If you can answer to this question, I was trained to use a no suicide contract when managing a client experiencing significant suicidal thoughts. If we can pop put that poll up. There it is. Okay. I know everyone's here, like we have some recent graduates, we have some probably graduate students, and we have some people that have been in the field practicing for decades. So okay, I think it's probably enough time. Let's see. Okay, so about a quarter of you were trained to use no suicide contracts, and about a third of you are not sure what they are. So that's great. Well, actually, yeah, so 3/4 of you were not trained using that. That's good. That was kind of an old, I don't want to say old school, but that was kind of an old thinking process. If we could contract someone, if they're thinking about suicide, and have them sign a contract to commit to saying that they will not attempt or die by suicide, then that would help them and reduce their likelihood of dying by suicide. And what we know is the research does not support that. So so these no suicide contracts, it would just be an outline of like, I'm not going to do this. You sign and date as the clinician, the therapist, and then the client would sign and date. And and I can think about my graduate training, and one of my very first clients when I was a graduate student. She was like 18, 19 years old. And we completed this because she was, had a lot of suicidal thoughts. And she also engaged in non-suicidal self-injury via cutting and other forms. And she was really committed to getting better, and was committed to living life. And so she wanted to add the non-suicidal self-injury to the contract. So we added that to the contract. And I think one of the issues of a contract is there's typically an end date. So for us, we did session by session. Well, the next session, she did not show up. And so I was a little bit worried, and I ended up calling, and she wasn't picking up. And it wasn't until probably a few weeks later. I mean, I checked in and called a number of times over the course of the next 2-3 weeks. And finally she, called and came back in, and we talked about it and what happened. And she actually, the contract expired on the day that we were supposed to meet, so it no longer applied. But aside from that, she had engaged in non-suicidal self-injury by cutting, which negated in her mind the entire contract. And so that kind of gave her leeway to be able to, in her mind, to attempt. And it was a fairly severe attempt, and a couple of attempts actually in that course of time. And a lot of people may not realize that these things don't hold up in court anyway. So that gives a therapist a false sense of security, and that maybe will be covered in case if something does happen, and then the family or someone sues the clinician or brings a malpractice suit. And I think someone might argue is like, well, can someone contract for safety if they're not necessarily of the right mind? They could say, they might argue that their capacity to consent was impaired. But anyway, I'm glad that most of you are not trained in this any longer, and it's not useful, but I think it would give a lot of therapists a false sense of security. And so safety planning is very different, because we do sign this document as an agreement, but it's not a contract. It's a plan. And I like that. When I started working at this hospital, that was the focus. We talk about safety planning rather than no suicide contracts. Most of you are familiar with the Columbia Suicide Severity Rating Scale, the CSSRS. We use that in our suicide prevention program. We have an intensive outpatient program. Oftentimes we use it for research as well in our hospital setting. And it's well done. It's a very thorough risk assessment and documenting, and being able to look at risk overall. But I should also mention that there should be focus not so much on predicting suicide, but on preventing suicide. Those of you that are familiar with David Klonsky, who is a suicidologist out of British Columbia, he did a webinar for the Collaborative Assessment and Management of Suicidality, or CAMS, last year about the state of suicidology and mistakes and errors that we make. And we spend so much time trying to predict someone when someone might attempt suicide, what risk factors are at play. And when in reality, there's that meta-analysis that a lot of you may have read in 2017 by Joe Franklin and colleagues that found that we're no better at predicting suicide than we were 50 years ago, and predicting suicidal thoughts and behaviors than we were 50 years ago. And no other field looks at predicting probability of cancer or heart conditions, cardiovascular, strokes. So they focus more on prevention. And even if we could predict, which he argues that we can't successfully predict, even if we could, it's where we go from there. And especially if you have so many people who are likely to attempt, but then they don't. So it's really kind of a waste of time, he argues. But anyway, focus is less on predicting than more on just focusing on preventing. The next is through the, like I just mentioned, CAMS, Collaborative Assessment and Management of Suicidality. Out of this came the SAFETY through the Substance Abuse and Mental Health Services Administration. Has 5 different steps here, and then comes up with gives you a risk level of high, moderate, or low, and then potential interventions. I don't use this as much. Actually, I don't use this one at all, but I use elements of it. I use elements of the CSSRS, but I actually don't measure or screen in this way as much as I just do a verbal interview, like a lot of you might. But if you're in a clinic, maybe a primary care clinic, these may be useful tools in addition to the PHQ-9 if you're using that. So these are supplemental if you'd like to use them. The SAFETY, the suicide assessment, 5-step evaluation and triage. And I put a link there for you to be able to access it for free. I think you can actually like buy little cards if you want of it. And then you have the Ask Suicide Screening, the suicide risk screening tool. So ask suicide screening questions. We do use this in our hospital. And here's like a little interpretation. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you and your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And 4, have you ever tried to kill yourself? So if they say yes to any of those questions, then you ask the 5th question, which is, are you having thoughts of killing yourself right now? And then have the next steps below that to be able to provide some guidance here. And if you do work in a large system, I know there was a task force that one of the task force for the US published something a couple of weeks ago, I want to say, that came up on the American Association of Suicidology listserv about how we need to stop screening everyone, all youth, for suicide. Yet we know that 1 in 5 have seriously considered attempting suicide in the past 12 months. But they say we need to stop screening universally, and because that could stigmatize individuals as well as it's a waste of resources. There are a couple studies that actually show that it does not add burden to the health system. So universal screening for suicide can be effectively managed. Actually, here in Dallas, where I am at Parkland Hospital, it's affiliated with UT Southwestern Medical Center. It works as the public medical center here, Parkland is, and that was introduced, universal screening for all ages, adults included, and found that it was well put forth and carried out, and found that it did not add burden, it did not add financial burden to the system, and actually identified a large number of individuals who otherwise would have been missed had they not been asked about suicide, and they were able to be provided care and intervention. And then as far as stigmatizing, other suicidologists and suicide prevention, including the Suicide Prevention Research Center, argues against, and I would argue against, that universal screening would stigmatize individuals, because we know that itself could be stigmatizing, saying, oh, we don't want to ask this because it'll stigmatize them. It was like, well, you're saying it's not okay to ask, then that itself is stigma. But I wanted to focus more today on the safety planning intervention put together by Barbara Stanley, because we use elements of this as well as CAMS and these other when it comes to actually safety planning. So you can screen if they screen positive in any way, and if they're or just endorsing suicidal thoughts in general. A lot of you are already using the safety planning intervention. And in 2018, so that was 2012, Barbara Stanley introduced it. And in 2018, they actually looked at in the emergency department, comparing those who were in safety planning intervention plus receiving like a follow-up telephone call a couple times over the subsequent weeks versus usual care or treatment as usual of youth who are or individuals who are treated for suicidal thoughts and behaviors in the ED. And I don't think, and here's kind of the results. And those who were in the suicide planning intervention plus condition, which again was the plus means the follow-up calls, they were less likely to engage in suicidal behavior than those receiving usual care during the 6-month follow-up period. So that's good news. And it was also associated with 45% fewer suicidal behaviors, approximately having the odds of suicidal behavior over 6 months, having the odds, so like cutting it in half. And so that was, and then intervention patients had more than double the odds of attending at least one outpatient mental health visit if they were part of this group. So there's good data, promising data that this is a helpful intervention. And if you pull from the 2012 safety planning intervention itself, this is a screenshot of the figure 1 and the original, I guess, published safety plan through Barbara Stanley and her colleagues. And they break it up into 5 different steps, followed by making the environment safe. And I think all basic elements of a safety plan are going to have these core components in whatever way or using whatever terminology. So I'm going to share with you kind of what we do in our clinic, what I do with the kids that I see. I complete one of these probably on a weekly basis at this point. And so I'll kind of walk you through it, and then we can discuss and you can share what are some strategies that you use. So step 1, warning signs. Step 2, internal coping strategies. So things that I can do to distract myself without contacting anyone. Step 3, social situations and people that can help to distract me. Step 4, people who I can ask for help. Step 5, professionals or agencies I can contact during a crisis, and then making the environment safe. Now you can see this is applicable to all ages. This next one is going to be more applicable. This is what we use in our clinic, and it's applicable more toward young people. So we get the parents on board. Now, if you have a paper and pen, or maybe you can use your own phone in your notes section, I'd love for you to complete this and just kind of follow along with me so you can kind of know what it's like to create a safety plan. So you know what it's like for your client to create one, your adolescent client in particular, if you're seeing them and treating them for acute increase in suicidal thoughts. And I usually do this with the parent present or without the parent present. Sometimes, and I kind of make it up, give the decision to the adolescent. And if they don't want the parent present when we develop it, I do request that the parent come in at the end to review it and agree upon it, because I want to make sure that parents are okay with what's on there. They might put someone on there that's a friend or a family member that the parents are like not okay with. And so that's going to negate that that space or that portion of the safety plan. So I want to make sure they're on the same page, and I want to make sure that the parents are on board with everything there. I'm going to send them home with at least one copy to share, or one copy for both the child and one copy for the parent. They can use, sometimes they'll put it up on their refrigerator. Some families are okay with that. Oftentimes they just kind of put it in their next to them, their bed on the nightstand. But I like to always have it easily accessible. And we may review the safety plan and update it over time. I'm actually terminating not tomorrow, but later this week, with a student that's going off to college that I've seen over the past 4 years, who's had varying levels of suicidality or suicidal thoughts, has made multiple suicide attempts earlier on in middle school, and safety plan we had to update it later on when he was in high school because certain people were no longer there anymore. So yeah, so you can always revise, update this. Sometimes I'll just pull out the same copy and we'll change it then and there, or get a fresh copy and then redate it. So this is kind of how we structure it in kind of 3 sections. So that the top part is planning ahead, which talks about making the environment safe, which in the previous slide, it was at the very bottom. And then the second is identifying warning signs. And then the next section is the actual safety plan. So sometimes I will skip the identifying the warning signs, but I will usually start here, especially if I've done the suicide screening and asking them about what methods they might, if they've thought or if they disclosed. And oftentimes it's the medication that they have, they may start saving it up or cheeking it and hiding it to ingest later. Or if it's a firearm, and that's a more of an alarming concern for me. Or if it's cutting, or if it's a lot of adolescents might say self-strangulation using a belt or a wire, but that's still I take seriously, because who knows what might keep them from latching it to an elevated place in their home and actually suffocating through hanging. So making the environment safe, what I can do to make sure I'm in safe situations. Again, usually this is where I'll cover with make sure the parents are on board and and talking about locking away medications, because that's a very common method that a lot of the young people may attempt, even though it's not as always lethal. But I mean, we're at a children's hospital. We've had deaths that have resulted from overdosing intentionally as a suicide attempt. And then those that may have survived and they're placed on like transplant list, and there's the ethical concerns there, and the organ transplant team trying to decide what to do with, are they eligible. So some clinicians, I mentioned, advise locking away sharps. I usually recommend locking away medications and temporarily removing any firearms in the home. And because they're clearly the most lethal, and 80 to 90% of intentional self-inflicted gunshot wounds we know are fatal. I'm not sure how many of you have completed this or are aware of the Counseling on Access to Lethal Means. I have we have an APA accredited postdoctoral psychology fellowship in our hospital, and I supervise one of our postdocs in further therapy cases. And because we get a large number of adolescents who come in with suicidal thoughts and behaviors and histories of attempts, and I live in Texas, where firearms are really important, I always have our postdoc, if they have not completed this training, it's a free training. I ask that they do at the beginning of their fellowship year, and it's a good review. I've reviewed it probably a year or two ago, and probably will review it again just to keep up to date and see how they've updated the material. But if you haven't done this, I know a lot of you probably have, but I encourage you, if you haven't done it, it's a great resource. It's free. It doesn't take that long. And it's really interesting how the video footage of the clinician therapist talking to a family to parents about temporarily removing their firearms from the home in order to decrease the access that their teen would have, because that's the thought that this teen has had as far as suicide, is using the firearm in the home. But they're very, some families are very, their firearms are very important to them in their lives. And so we don't necessarily want to say, get rid of them or throw them away, because then they're probably going to be less likely to follow our recommendations. I talk to them about, at minimum, locking them away separate from the ammunition and locking that away. But so many teenagers, I mean, they know the codes, they know where the keys are, they just haven't told their parents. So the parents, they don't know. So that's possible, but teenagers are pretty savvy and they can figure these things out when it comes down to it. So the safest home and during this time is at least temporarily removing the firearms from the home. And it can be a very sensitive conversation. So I think they demonstrate really well in this training how to have that conversation with parents. Back to the safety plan. So that's why we know, like, if I know with a method in mind that the kid has, like if they're thinking about jumping off the top of the school roof. And I mean, I've had teenagers who said that that's the thought that they have, and their school is high enough, it's tall enough. I mean, not all schools, or some schools, high school I went to was like 1 story or 2 stories, but it wouldn't have been high enough to harm anyone if they were to fall off or jump off. I mean, maybe break a bone but likely not die or have significant medical problems as a result. But having seen a client before in my work who their school was high enough, and at least to be at risk for potential significant damage or death, there was a ladder with access to the roof, and they knew where it was. They'd been up there before. And so we had to talk to the parents and the school about how to prevent access to that. So it's good to know what thoughts they might have if they're thinking about jumping off a bridge and they don't have, it's like, I want to know where they live or what bridge they're thinking about. And they say, well, I talk to the parents, like, there's no bridge nearby. So that's good. But we want to be mindful of any bridges and overpasses, like in the highways, like here in Dallas, and I'm sure in New York, you have some pretty tall overpasses that are very high. So identifying warning signs, we call it at-risk times for having suicidal thoughts or depressed, irritable mood. A lot of times for teenagers, it's conflicts with their parents, arguments. I'm asking them to become a little bit self-aware. Maybe they recognize that when they're more isolated, they tend to stay home and away from friends and in their bedroom, online playing video games more and more. They might start to have more suicidal thoughts. So I want them to be aware of that and have that self-awareness so we can intervene if needed or use the safety plan. So sometimes it's getting a bad grade, failing in class or failing a test. Those are at-risk times, or having a breakup oftentimes, or an argument with a boyfriend, girlfriend, significant other can be warning signs. So I want them to start thinking about this, especially if they're having suicidal thoughts. And that's why we're doing the safety plan and what puts them at risk. But now we want to talk about the actual core elements of the safety plan. And this is where I like to spend the most time. And here there are 6 spaces for each one. When I was working inpatient, acute psychiatric inpatient in the child adolescent program in Miami for my predoctoral internship, before every kid left the unit, we made sure they had a list of 10 coping strategies. So I still like to do that and bring that into my work. I like to have at least a list of 10 different things that they can do, with at least 3 under each of these categories if I can, each step. So there would be 4 under 1 and then 3 and 3 at minimum. Some kids can like fill this out really well, and the more the merrier, but a lot of times they're so overwhelmed they may not be able to think of what's very helpful. So step 1 is just basically things I can do on my own. So I recently did safety planning about a week ago with a teenager who said, well, I want to start with step 2. I was like, that's fine. We can start wherever. And then step 2, the with someone coping, the things I can do with a friend or family member to help me cope. He listed the same person like over and over, like, and everything. We'd go to the movies, we could do this, we could do that, go play tennis. And it's like, that's great. But what if it's 10 p.m. or midnight and he's not around, or maybe he's sick that day and you're struggling. What can you do with someone else? But also, if we go back to step 1, what can you do by yourself? And so if you know your client really well, you know the teenager really well, you can ask them about the things that they enjoy doing. Like, oh, I know you like journaling. Does that might that be helpful? And so usually in my intake, I always ask them like what they like to do for fun, and then I'll say like, well, let's just add that to the safety plan. Especially if they come to me and they're having during my initial intake with them, they're having these suicidal thoughts. I also like to at least have one, not just distraction, because a lot of these on my own coping are what I would call more like your basic coping strategies that are very they're just distracting. Watch Netflix. Well, that's not hard. You just turn on listen to music, very passive things. So I like more of the active things they can do on their own. Journaling is great because it can be great, at least because it's more of an active strategy. I also like to have one what I call cognitive coping strategy. So one thing that they can tell themselves in a moment in which they're thinking of suicide, to kind of count. If you talk about like CBT, try to counter that with a more adaptive thought as far as like, I can get through this, or this too shall pass. And I'll just kind of ask them like, and I'll give, a lot of times they don't understand what I mean by that. I'll say like, think a thought coping, because it's more advanced and it's harder to do in that moment. And so I'll give them some examples if they are struggling, and then they can come up with their own or choose from one of those. And then we'll go to step 2. So things you can do with a friend or family member. And a lot of times they get stuck because like, I don't want them to know my business. And here we're not talking about like disclosing your deepest, darkest secrets. Sometimes we just need to hang out with a friend to feel better without having to like, you just laugh, or you just their presence. You don't need to disclose having suicidal thoughts to them. Maybe that's helpful, but for some kids that's not going to be helpful. Like another teenager might not know what to do with that information. So we talk about things that they can do with other people, cousins, family members. And then step 3 is the tell someone of an adult. And a lot of times this is where kids have a more difficult time. I typically like to have at least one parent on here, but I understand that's not always realistic, or one caregiver, I should say. And that's not always realistic because they might not be the safest person, and they might be contributing to this, to the suicidal thoughts and behaviors, and might not have an appreciation or understanding of mental health, and might stigmatize and shame their child. So I have to be aware of that. I still like to try to, the fact that they brought them to me for therapy or for an intervention tells me that at least their parent cares about them to an extent. And so sometimes I can tell that way to the student. So tell someone like an adult. I typically like to see if like it's a parent, adult family member, grandparent, adult cousin. So not like your 17-year-old cousin, 18-year-old, 19-year-old cousin, still kind of iffy, but aunt, uncle, teacher, school counselor, mentor, coach, boss, manager that they have a good relationship with. Again, not necessarily having to disclose the suicidal thoughts, but those would be the people that would be better to disclose to than maybe another teenager. And then down below, you can have professionals to ask for help. I actually changed this up, the safety plan up. This is our hospital-wide one. And so I put my name for the therapist name. I don't typically put myself in step 3. And then we all sign at the bottom, and there's the patient signature, or you can client signature, provider signature, which would be us. But then there's the therapist signature, which is the same as the provider. So it's a little, so I usually will sign under the therapist signature and cross out provider and just put parent. So you can create your own, and for your clinics if you haven't. And then lastly, let's say you've created a safety plan, and they might still be struggling with suicidal thoughts here and there, but they haven't attempted. And one thing I like to do is switch to some problem solving type therapy. We know it's problem solving therapy is evidence shows that it's useful, at least in some cases, including non-suicidal self-injury, for instance. There's some evidence that it's helpful, but we use here, I mean, there are different acronyms that you can just Google, but we use, one of our psychologists here, Betsy Kennard, developed this with I think Jenny Hughes and a couple other psychologists at our hospital. This acronym, flip the problem. And there's actually another side to this where it's just a simple example of a problem that a student had with a bad grade on a test. And so they figure out what the problem is, what you want. In that case, they wanted to get a better grade, list all possible solutions. This is where teenagers really struggle, and adults probably, because they usually come up with like 1 or 2 different solutions to their problems, identify the best solution, and then plan when and where to use this strategy. So I'll sometimes apply this in retrospect to a past suicide attempt. So last month, I think it was last month or recently, I did this with a 17-year-old that I see for therapy, and it was the 1 year, like 1 year since she had attempted suicide, that ended up in the medical program for a couple of days with a significant overdose. And so we applied this to her suicide attempt, and because she was already anxious about the upcoming 1 year mark of her serious suicide attempt, and went back in time and said, what was the problem, and what is it that you wanted? And then we listed all possible solutions, because in that mind, and I talked, these teenagers, we become myopic in our view, very narrow focus. We don't see the forest for the trees. It was just, all we see is no light at the end of the tunnel, and suicide becomes seemingly the only option. But I wanted to broaden her horizon in case she was triggered again by the 1 year mark of her suicide attempt, and look at other options. And then we listed a bunch. And then I asked her, what's the best solution? And I think for her, it was walking the dog. And I was like, at 10 o'clock at night, that would have been okay. She's like, yeah, actually, it's safe enough in my neighborhood to have done that. My mom would have been okay. I'm like, okay. And then the plan, when and where to use the strategy, she would have used it then and there. But then it's like, well, what if that doesn't work? Then we go back up to the L, list all possible solutions. And then the next best solution was calling a friend, and a specific friend in particular. And so looking back, she's like, if I had done either of those things, I likely would have felt a little bit better and not have attempted. And so that was really important for her. So I use this sometimes after months, usually not within weeks, but within months, if a kid is in a better spot, and I know that they may be at risk for reattempting, I want to broaden their horizons, especially if it's a similar problem that might trigger suicidal thoughts, so we can tackle that early on. So we have 16 minutes for discussion, Q&A. You can email me. There's my email. I'm on Instagram and Twitter. And then there's the podcast that we mentioned at the beginning on the psychology of non-suicidal self-injury, but obviously it's a risk factor for suicide, so I put that here.
Thank you so much, Dr. Westers. And thank you everyone for all your chatting and questions. Many people are liking your flip strategy and some of the other content that you mentioned. So we do have a few questions. I'd like to get into it to have time to answer. And please continue to chat in your questions, because Kiara and I are going to keep gathering them, okay? To start, we have you studied or do you know about the influence of social media and increasing thoughts of suicide in teenagers and younger age children?
In younger age children, yeah, this is common. I think I presented on this for CTAC back in October, and what we know and don't know. I think it's an easy scapegoat. There is some research showing, particularly for certain youth, that it could increase risk for suicidal thought, increase risk for depression and anxiety. And I think that's especially true for adolescent girls, unfortunately. But for younger children, I'm not exactly sure what age group you're referencing. But I mean, I do think that it's an easy scapegoat to say that increased use of social media is going to increase risk for attempting suicide. I don't think we have that data to my knowledge. Someone might be able to put it in the chat, any recent studies, but I'm sure it doesn't necessarily serve as a protective factor unless it's used. Actually, the real question is how is it being used, and for whom is it a risk factor? Social media, that is, because I think it can be used during the pandemic, for instance, and even now to connect with friends. And so to not have that, then the person could feel very lonely and disconnected, and could place them at greater risk for at least ideating about suicide, if not attempting.
Mhm. Great, thank you. Kind of on that note, but different, is there a screening tool that is formatted or focused for younger youth, ages 8 to 14, for example?
The screening, I would say the ASQ. So we use that here, and I believe for ages 6 to 9. I actually wrote a paper and recommended this based on our hospital practice here, where so being able to screen all individuals 10 and up, all children, adolescents 10 and up for suicide, and then for those that are under, because we know, I think, recent data showed that 43% of ED visits for suicidal thoughts and behavior were for 5 to 9-year-olds. And so I think in those cases, screening using the ask screening for 5 to 9-year-olds or 6 to 9-year-olds that show up for the ED specifically for behavioral concerns, or because they have already endorsed or made comments about suicidal thoughts and behaviors. And in these cases, I mean, a kid might not necessarily know the finality of death or what suicide means or is, especially if they're younger, like 5 or so, or 5 or 6. We typically would recommend asking the parent if they have made any comments or if they've seen anything or noticed anything. And so screening through the parents in those cases would be the more useful way. So I think that, yeah, the ASQ, the ask screening instrument would be helpful.
Thank you for that. Great. We have some questions coming in, but we did have some already, so I'm going to just keep going. Some clinics do not really involve parents at the teenager's wish. However, what do you recommend there? Is there also an age that the teenager can make decisions themselves?
Yeah, so this gets tricky with state laws. I don't know, I'm not familiar with New York state laws. I know in Texas, children and adolescents can seek treatment without parental consent for abuse, suicidal thoughts and behaviors, and substance abuse, misuse. And I think maybe one other reason. Now, that doesn't mean the parent, if they get a bill, that they'll pay for it, and they don't necessarily have to pay for it if they didn't consent for it, but they don't necessarily need the parent's consent. But I think what this question is alluding to is just that the confidentiality that's so important with parent and with adolescents and working with their parents. And so as a member of the Society for Adolescent Health and Medicine, I mean, that's like really drilled in as far as confidentiality and privacy for adolescent clients, adolescent patients. And so it can get a little tricky, but I also think some may err on the side of, well, the teenagers don't ever want their parents to know. And sometimes they do. I think they just don't know how to tell them. And sometimes I'm supervising a case right now where the kid is very acutely suicidal and is at risk. And we have our suicide prevention program, but didn't want to go to attend. And even though this child really needs it, and the parent was not making them. And so I think as clinicians, it's okay sometimes, and I have to work with my trainee to say, it's okay, like, this is the plan, this is the next step in treatment, and telling the parents, like, this is what needs to be done. And fortunately, this child is now in the program. And when the parent made the decision, and my supervisee enforced it, the child suddenly became relieved, like, okay, now, like, that power is out of my hands. And so in this case, that was really helpful. But if we talk about informing parents, typically during your informed consent process, you're going to be telling the child and the parent what limits there are. And I think it's pretty much nationwide that the limits include child and elderly abuse or neglect, as well as suicidal thoughts and behaviors, or or risk of harm in that way. And I think imminent risk and imminent harm is very subjective. Like, what does that mean? Does that mean you, again, predicting? Okay, we're not very good at predicting these behaviors. So, and if we were, does that mean predicting today, within the next hour, within the next week, within the next 6 months? And most research that looks at predicting factors, they look, months down the road, but as clinicians, we want to know right then and there. So I think sometimes it's okay even to just draw that line in the sand with the child. For instance, my supervisee as well, I can see I work closely with our fellows here in training them. Said, hey, would ask the teenager, I think this is a different child, can we do a safety plan? And the kid's like, no. And so I inform our trainee, our postdoc, that it's okay to say, oh, okay, I'm concerned, and this is we need to do a safety plan. Let's do a safety plan, and then we can involve your mom now, or your dad, your caregiver now, or at the end, up to you. Kind of give them, and sometimes you don't necessarily have to do that right then and there until after you create the safety plan. You can mention that while you're developing, is like, hey, I want to make sure that, is your mom okay, your dad okay, your caregiver okay with this person on here? Are you doing this? Because we're going to check with her to make sure, check with them to make sure that it's okay. So, but of course, I don't safety plan every single session, like create another one. I might pull it out if they're really struggling and review is like, hey, this is on here. I'm curious to know how that was helpful. Oh, that wasn't helpful. Like, okay, that's why we have all these different options. We'll try this and we'll revise it. We'll update it. We'll add things to it, to remove things from it, and we'll revisit it in the future. So I don't think parents always need to know every single session, especially if the kid is chronically endorsing suicidal thoughts. But if it's at an elevated level and then I'm bringing parents in every session. But usually there's when I see a lot of elements that are increasing risk, like failing grade, a conflict with boyfriend, girlfriend, something different, like a life event, then I think, okay, that's a different presentation and a greater acuity, and then I'll bring parents in. So.
Okay, thank you. So it's tricky, but
Yeah.
Ideally you're always involving the caregiver with someone under the age of 18.
Yeah.
What would be your first response when you meet a young person who has expressed suicidal ideation?
Well, first I would likely have asked about it. So kind of my terminology, I might ask. There's one thing we screen everyone here in our hospital, like even if they're one of the things that we have to document is suicidal thoughts, abuse, bullying, and non-suicidal self-injury. And so I might ask, it's like, have you ever thought about, well, usually I already know, that's why they come to me. So they've endorsed that. It's like, so I understand that you've had some suicidal thoughts. When was the first time you had this? So I want to get a timeline and see how chronic this has been. And when was the most recent time? And so maybe it was 2 weeks ago when they made the appointment, or maybe it was currently. And so I have a timeline, and sometimes we can ask about the time where it's the worst that they've had it. Usually by then, if they've attempted suicide, I kind of know at that point. But I might ask them, have you thought about what you might do? And sometimes kids become sheepish with this, but I think if we ask in a matter of fact, non-judgmental way, these are conversations I have every day, so I'm so comfortable with it. I think kids just kind of naturally respond and disclose. Sometimes they're really anxious though, if they've not, in their first appointment, so they might not tell me, or they might be a current client for many years or many months or years, and they know what string of questions follow, and they know how to respond in a way that'll get me to just yesterday, to the sudden distress of on a subjective units of distress scale. Suddenly it's a 9 out of 10 when it's been chronic, lately a 0 or a 1, related to suicidal thoughts and behaviors. But I kind of know this individual, and I kind of, but I'll ask them what have you thought about what you might do, or what have you thought about doing, and I'll be able to assess some lethality and concern there. If it's overdosing, then I'm like, okay, I know they're taking medicine, and we're definitely going to make sure their parents are involved. So I eventually will get to that. But if it's something like cutting, then we'll talk about access to knives or sharps. And I'm a little less worried, but I still don't want to say, oh, not an issue, because then, yeah, that might have the opposite effect, because people can still die that way. And then I might use scaling questions, 0 to 10, like as far as, and I think one of the handouts I pulled from one of my favorite books that I recommend to our postdocs that come in every year, called Treating Depressed and Suicidal Adolescents by David Brent, Kimberly Poling, Tina Goldstein. I think David Brent, at least, I think is at Pittsburgh, but it's a great book, and I have our postdoc. I recommend, I can't require it because you have to buy it, but I recommend it's a great resource. And I created a handout with different questions, including scaling questions that you can use, that I think they're going to put in the chat if they haven't, if Kara hasn't already, or Kira. And I might say, like, on like 0 to 10 scale, like 10 being the most intense you've ever had these thoughts, where are you today? And so maybe that would be like a 6. And where were you this past weekend when you were saying you're really having it? Oh, I was at a 10. And I'm like, oh, well, what kept you from acting on those? And I want to bolster like those coping strategies. So, yeah, so those are just some examples of what I might say.
No. So it sounds like you're gathering the timeline, kind of gathering the chronicity, and also really doing a deep dive on assessment. So where are they today? Where have they been? And then how can you build the coping?
Yeah, and we know that asking about suicide is okay, and talking about it, if anything, it decreases their likelihood of attempting if they thought about it. That's what we know from research, and I think everyone on this presentation knows.
Yeah, so we need to be very comfortable in having conversations, for sure. And it's scary, right? It can be really scary, but the more you talk about it, the more helpful we can be, right? We do have a few more questions I want to get to. We have someone that says, I recently opened a case with a teenage youth who has significant NSSI behaviors. Some of these behaviors have been potentially lethal. The team reports youth harms as a means of gaining control. So they decided not to lock Sharps, as he would find something else anyway. Thoughts on the safety plan? It goes against everything I've been taught.
Yeah, so actually last month I did a presentation on non-suicidal self-injury. I think it's available through CTAC, and we talked a little bit about NSSI as a risk factor for suicide, and and sometimes there can be co-occurring suicidal thoughts, and that's more in the method. If the method itself is like cutting, then I'm more worried. If method of suicide that they're thinking of is through cutting, even though it's really unlikely to die that way, it's, like I said, it's possible, even accidentally, cutting the wrong place or too deeply by accident, in non-suicidal self-injury. So I think if another example is having a teenager here that we have now who gave the blade, to her therapist, and because she asked for it, so she decreased the access to the means. Well, and I did that with my first client back in grad school, the one I mentioned, who had written that, signed that no suicide contract. Well, she had like 10 more at home. And so it's like, I felt like, oh, that was a great deal, but we do have to learn to function in a world with sharp objects, including razors, scissors, knives. And so I think there can be temporary means, but then we want to make sure if it's about control, then there's that power struggle. And that's not helpful either, because the more we try to push, if this is non-suicidal, if it's suicidal, then yeah, I would definitely put that on the safety plan.
Okay, great. Thank you. For children and teenagers who are struggling with school being their biggest trigger for anxiety or depression, what are your thoughts about completely pulling them from school and allowing them to do online courses?
Oh, I'm sure everyone on this call has an opinion here. That helps immediate and decrease their immediate anxiety, but impairs them in the long run, right? And so coming up with a back to school plan, anxiety, the hallmark of anxiety is avoidance. And so we don't want to pull them out. I recently had this, but this kid was not wanting to go to school, and finally disclosed, though, that it was because her abuser was one of the students there. And I didn't know that. I was like, oh, I would never encourage you to do that. But we did, find another school that has, it's a smaller school with online components. But typically, even with the pandemic, I don't know anyone that switched to virtual, even those with social anxiety disorder, that have succeeded or have done well or thriving as a result of online school if they hadn't already been doing it before. So I think online school has its place, but I think as a safety behavior for anxiety only reinforces it and impairs the student rather than helping them through the long run.
Thank you. We're running out of time. Would you mind just going to the next slide? So
Yes.
keep talking about this with the people that you're seeing and keep being a support. And thank you everyone for all the hard work you're doing. This is not easy, and so important to protect our youth who, you're right, that young people don't necessarily realize the severity of their thoughts and their actions. So we have an upcoming key training, Knowledge Empowers Youth. Knowledge Empowers You, Wednesday, May 25th from 11 to 2. We have parental conflict as a traumatic stressor for children and adolescents, awareness and ways to intervene, Thursday, May 19th. And we have creative family therapy techniques coming up on June 7th. So please join us for those. And also Dr. Westers has presented several times on this topic. And we're so grateful for you sharing all of your expertise and wisdom with us. So we will be sending the handouts to you as well as recordings from his past webinars that I think will also be helpful. So thank you again, Dr. Westers, and have a wonderful day, everyone. And thank you again for all the hard work that you do.
Thank you. And thank you for having me.
Okay, take care, everyone. Bye-bye.